Welcome back, everyone. Dr. Jenkins here. This is going to be part 2 of the blood chapter. As you may recall, in part 1, we went over the general functions of the cardiovascular system, and then the functions of the blood, properties of the blood. Make sure you're reviewing such fun things as osmolarity, viscosity. Then we talked about, we talked about the components of blood, plasma, the plasma proteins, and then we began the formed elements, and we discussed erythrocytes or red blood cells. So we're going to pick up where we left off, and now we're going to talk about the leukocytes or the white blood cells. So here we go. When it comes to white blood cells, they are structured very differently from the red blood cells. You may remember the red blood cells. I know you do. Red blood cells have a circular shape, but they're concave in the middle for more surface area. And of course, we remember that red blood cells do not have a nucleus. And I'm not sure if I mentioned this before. I don't think I did, but I'm going to mention it now and make sure you know it. The reason why red blood cells don't have a nucleus, as a matter of fact, red blood cells don't really have any organelles. Right? The reason why red blood cells don't have any of those organelles is because it makes the most space possible for hemoglobin to transport oxygen. So it's really a function. By getting rid of all the organelles, it just leaves maximum space for hemoglobin so it can carry oxygen. Well, now we're going to talk about the white blood cells. White blood cells are larger than red blood cells. So in this little schematic, in this picture in the bottom right corner, we see a bunch of white blood cells. This is a white blood cell, this is a white blood cell, this. Well, they're all bigger than the red blood cells. And if you look inside, they have a nucleus. In some cases, they have nuclei, like this little guy down here, or gal. So structurally, white blood cells are different than the red blood cells. They're larger, and they contain a nucleus or sometimes nuclei, which is several nuclei. When it comes to the number, we have less white blood cells than the red blood cells. So remember, red blood cells we have the most of out of all the formed elements. You remember this? Out of all the formed elements, it is about 99% red blood cells. A much smaller amount includes white blood cells and platelets. The function of our leukocytes, or white blood cells, is really all about immunity. So these are the cells in our blood that help us fight infection. All right, I'd like to make a little point here. And I'm not sure the words on the screen do it that well, but fortunately you have me, you have my words. That's why I get paid the little bucks, you know. When it came to red blood cells, and I'm going to use red for red blood cells. When it came to red blood cells, all red blood cells, well, it's hard to say all when it comes to anatomy and physiology. Let me put it to you this way. Most red blood cells circulate in the bloodstream. So let's say we have 5 million red blood cells at a given point in time in an adult. Well, the majority, most of those 5 million red blood cells are constantly circulating in the blood. When it comes to white blood cells, it's a little bit different. So when it comes to white blood cells, some white blood cells are always circulating in the blood. What we're going to find is that the neutrophils, which are the most common type of white blood cell, they're going to be the ones that are circulating in the blood. Just ignore that message. It worked last time with the recording, so fingers crossed. But then there are other white blood cells that stay in storage. which means that they're released only as needed. So there's a difference here, okay? In red blood cells, the majority of them are always going to be circulating in the bloodstream at all times. Yeah, we do store some red blood cells in the spleen, fine, but still the majority of red blood cells are going to be always in the bloodstream. But when it comes to white blood cells, there's some white blood cells that are always circulating, but there's other white blood cells that we keep in storage. And what this means is only when our body's encountering some sort of infection, only then do we release the other white blood cells. Think of it like, and when we get to this chapter later this semester, I'm going to use the analogy of our white blood cells being like soldiers in an army. Well, you don't put all your soldiers out right away, no matter what. You may have some soldiers out for surveillance or for safety, as we have some white blood cells that are always circulating, right? So we have some level of immune response, always. But then the other white blood cells we keep in storage. In this case, what we're going to find out later is we keep some white blood cells stored in the thymus gland, for example. It's a big white blood cell storage site. We keep these white blood cells stored, and then only when we need them do we release them. Just like an army, when all of a sudden you come up to a battle, you bring in more troops. So just know that basic concept. All right, now when it comes to white blood cells or leukocytes, we've got 5 types. 3 of them are considered granular. You guessed it, because they have little granules. Like this little guy here is granular because it has little granules, granular. And then there are 2 other white blood cells that are considered to be agranular because they do not contain granules. What we're going to do is we're going to go over each of these types, and we're going to talk about the basic structure and then the basic function. Before we do that, I'm going to skip ahead for a moment to this, because I think this is a good way to start. It's a common saying to help us remember what white blood cells we have the most of and what type of white blood cells we have the least of. So we have the most amount of neutrophils. So think of never let monkeys eat bananas. We have the most neutrophils, then lymphocytes, then monocytes, and we have much fewer eosinophils and basophils. So even though I'm not going to ask you the specific number of each that we have, I certainly would like you to know which type of white blood cell we have the most of and which types of white blood cell we have the least of. So never let monkeys eat bananas, right? Okay. So here we go. Let's talk about neutrophils. Neutrophils are the most abundant. We have the most of them. Pretty much half, a little bit over half of our white blood cells are neutrophils. When we look at them, they will have a segmented nucleus. Now, in our lab for this unit, this chapter on blood, I'm going to be talking about this again, and I'll be showing you multiple pictures of neutrophils. And a neutrophil, you'll see it a lot because they're the most common, and it's one nucleus, but they're technically connected. So if I look oh so careful right here, there's a little connector. Boop, little connector there. Let me go back to this picture. So in this neutrophil, we can see it's one nucleus with different segments. Here's another one. One nucleus with different segments. One nucleus with different segments. Okay, so our neutrophils are most common. Never let monkeys eat bananas. Never. Neutrophils, most common. Structurally, they have one nucleus that has many segments. And in terms of function, they're going to be our generic, fighters. So these are the ones that are always in our bloodstream for the most part, and they're just our generic fighters, right? It almost doesn't matter what what pathogen it's being presented to, what type of bacteria, for example. These are like our generic white blood cells. Think about Pac-Man, right? In the game Pac-Man, the little yellow Pac-Man dude just goes along and eats up the bad guys. So our neutrophils, we can think of it that way. These are our generic white blood cells. When you think of a white blood cell, you're thinking of a neutrophil. They're in the bloodstream, and they're there to gobble up bad guys. All right, I'm going to go in order of never let monkeys eat bananas, just because it relates to their function. Our second most abundant type of white blood cell is a lymphocyte. So we have a decent amount of those too. Structurally, it's going to have one large nucleus. And oftentimes, the nucleus almost takes up the whole cell, as it does in that picture. I'm going to go back, and let's look at our smear here, and let's look for the neutrophil, or the lymphocyte, excuse me. Here's our lymphocyte, and indeed, it's like one big nucleus that almost takes up the whole thing. This one here is not as good of a picture. It's still a big nucleus, but it doesn't take up the whole cell. So probably in the lab, for example, when I'm going to show you pictures and ask you to identify what type of white blood cell it is, I'll be using a picture that really resembles the characteristics that we talk about. So for a lymphocyte, one big nucleus takes up almost the whole part of the cell. In terms of function, these are our what we call specific fighters. So remember I said that the neutrophils tend to gobble up pretty much anything? So if you think about Pac-Man, the neutrophil just gobbles up almost any type of bacteria. It's non-specific. It doesn't really matter what type of bacteria it encounters. It's just going to gobble up bad guys. Well, the lymphocyte is a little bit different. It will only fight or try and kill, as an immune cell, specific things. So it's our defense against specific pathogens. When I talk about this in our immunity chapter later this semester, I'll give the analogy of a sniper. So if we're still with the war anatomy or the army, the neutrophils are our generic troops. The neutrophils are just out there to fight anybody that comes in their path, non-specific. But here, the lymphocytes are our specific fighters. They're a little bit more highly trained, and a sniper's goal is to kill a specific thing. Same thing here. A lymphocyte will aim to kill specific pathogens. If you've heard of T cells and B cells, these are examples of lymphocytes, T lymphocytes and B lymphocytes. All right, cool. That was never let monkeys eat bananas. Neutrophils, lymphocytes, monkeys. The next type of blood cell, white blood cell that we have, is called a monocyte. So we have much less of it, as you can see here, but I'm not going to ask you the percentage. Monocytes tend to have, here it says oval, but I'm going to be a little bit more specific. So in terms of structure, let's say it has a horseshoe-shaped nucleus. Some people say that they look like earmuffs. So it's going to have a nucleus that has this shape. You could say U-shaped, horseshoe-shaped. Wait a minute, earmuffs is a different one. Hold on to that. I'm ahead of myself here. So monocytes have one nucleus, tends to be pretty big, and it's horseshoe or U-shaped. Let me just read ahead for 1 minute because I don't want to, so we'll talk about that with the inflammatory process. Okay. Monocytes tend to become macrophages, which also tend to do some generic fighting. Of course, it's more complicated than that, but in the time that we have, let's just keep it simple. So for monocytes, the function, let's just go with they differentiate into macrophages. And we'll talk a little bit later about what macrophages, what they're involved in. Okay, then we have the eosinophils. Never let monkeys eat bananas. Eosinophils. Eosinophils have a two-lobed nucleus. It may look like they're two separate nuclei, but usually there's a little strand connecting them. This is the one that I was thinking of, and I apologize. Some people say it looks like earmuffs. I tend to think it looks like boobs. If you've had me from A&P1, I'm never one to shy away from a reproductive organ analogy. All right, one of the things that eosinophils are specific to would be parasite infections. So of course they do a lot of things, but if I'm trying to keep it simple, so you can imagine on our first exam, multiple choice or matching, I'll have a list of the white blood cell types on one side, or one question, and then a list of functions on the other. Okay, so one of the things that's unique to eosinophils is that they are specific fighters to parasites. And the last type we have, the least common, never let monkeys eat bananas, is a basophil. Basophils have many small nuclei. Didn't spell that correctly, it's a U. Sometimes it almost looks solid, so you might mistake it at first glance for a lymphocyte because a lymphocyte has one big nucleus. But if you look more carefully, the basophils have many, many, many small nuclei, right? One thing that these are specific to would be assisting with the inflammatory response. All right, excellent. So as you review the types of white blood cells, make sure you review the basic structure and then one function of each. Excellent. Here's just another example where I put an example of what one looks like. You know, the monocyte, I gave you the example that the monocyte had a U-shaped nucleus. Sometimes it isn't always exactly U-shaped. This picture, for example, it's not a great picture. I probably wouldn't use it as a lab exam question, but I'm just pointing out sometimes it's not going to be exact. These are real things in the body. They're not perfect. Sometimes you'll see a monocyte also described as a kidney-shaped. So in addition to a U, if you see something that's kind of fat and kidney-shaped, that might also be a monocyte. But again, I'm going to give you pictures that really try and show the characteristics that we talked about. A good look at the whole blood smear, right? So if I look at the whole blood smear, you can see that we have so many of the red blood cells. Of course, they're much more numerous. And then in terms of perspective, we can see the white blood cells are much larger. And of course, they contain a nucleus. And then all those little spots, there's one, there's one. These are the platelets, which we're going to talk about next. All right. So up top, we have a normal blood smear. Down below, abnormal. This is what leukemia would look like. So in a cancer is a disease of the cells where the actual cancer takes over the cell. It makes it undifferentiated so that that cell that was previously, say, a lymphocyte, when taken over by the cancer, now it's a non-functioning generic white blood cell that can't do anything. And of course, cancers will cause crazy replication of these abnormal cells, and then they tend to clump together. I'm not going to ask you this on an exam. It's just a way to show you what normal blood smear would look like compared to abnormal. Here's some other abnormal ones. Let's see. If you look down here, this one is something called eosinophilia. So we see an abnormally high number of eosinophils, which are the nuclei that look like boobs. I'm not going to go more into this, but it's just some examples of how they might look different. All right. Back to the back to the differential if someone were to look at a blood smear. We already said that we're going to have the most red blood cells. We have much less white blood cells. I'm not going to ask you these numbers, but just to give you an idea, per cubic liter, or sometimes it'll be in cubic millimeter, 4 to 6 million red blood cells, and in that same amount of blood, we would expect 5 to 10,000 white. So much fewer white blood cells. Sometimes in a blood test, a clinician might look at a differential, right? So of those total number of white blood cells, what's the breakdown? Well, it should look something like this. We should have the most neutrophils, second most lymphocytes, and then monocytes, eosinophils, basophils. Okay, just like we did for the red blood cells, let's talk about production of white blood cells. Well, the production of red blood cells was called erythropoiesis. You may recall poiesis means production of, and then erythro means red blood cell. Well, here we have leukopoiesis. So the production of white blood cells is called leukopoiesis. Poiesis is production, and then leuko, as the prefix tells us, we're talking about white blood cells. Just like we talked about with the red blood cells, where does this leukopoiesis take place? The red bone marrow. So it turns out, my friends, that the red bone marrow produces red blood cells and white blood cells. Fabulous stuff. Now, I do want to make a distinction. All white blood cells will begin their life through red bone marrow. Okay, so all white blood cells are produced in the red bone marrow. However, after that happens, and I'm going to draw it out. So white blood cells are produced in the red bone marrow. Well, some are ready to go. Some leave ready to go. They're mature and they're ready to roll. So for example, the neutrophils, they're pretty generic white blood cells. They don't require a whole lot of specialized production. So the neutrophils are produced in the red bone marrow and they're ready to roll. However, other white blood cells require more maturation. An example of this would be the lymphocytes. Remember, lymphocytes, I gave you the analogy of the sniper. Well, a sniper just doesn't leave basic training from the army ready to go. A sniper has to take on additional training because it's a more specialized job that they do. Same idea, right? The neutrophils, some white blood cells, leave the red bone marrow ready to go. They're mature, done. But others need more maturation. And this happens in the thymus gland. The thymus gland, not to be confused with the thyroid. So the thyroid gland is more located in the throat, right? But the thymus is actually right above the heart. And the thymus gland, its main job, really, is to mature white blood cells. And as a result of that, it'll also store some white blood cells. So these white blood cells are produced in the red bone marrow, but then they travel to the thymus gland right above the heart where they finish their maturation. And then oftentimes they hang out in the thymus until they're needed. Excellent. All the rest on this screen is extra. Those are the key points. All right. What about the life cycle? Well, you may recall for the red blood cells, and I'm going to put those in red blood cells live, 3 to 4 months, right? 120 days. Well, when it comes to white blood cells, guess what? We're going to be very scientific. It depends. Some white blood cells live a short lifespan. Other white blood cells live much longer. You don't need to know the examples I've given here. Suffice to say, white blood cells, it really depends. Some live a short lifespan, some live long. I bet you all enjoy this slide. All right. I do want to talk a little bit about regulation of white blood cells. And as I'm wont to do, I like to do a little compare. It's also a nice review. So we talked in the first video about red blood cells and how we regulate the amount of oxygen in our body and therefore the amount of red blood cells. Well, we talked about red blood cells being regulated through a negative feedback loop. Right? Does this ring a bell? We said that among other organs, the liver and kidneys sense oxygen levels. If oxygen is too low, for example, excuse me, if oxygen is too low, it'll trigger a release of a hormone called erythropoietin from the kidneys, which then goes to the red bone marrow, which causes production of more red blood cells. Yes, you remember that. So red blood cells really are regulated by a negative feedback loop, kind of all across the body. Well, now let's talk about white blood cells. Some white blood cells I'm just thinking how I want to say this. Just give me 1 second here. Okay. Many white blood cells are really regulated by exposure to antigens. Foreign antigens, or we can call them pathogens, which is to say bacteria and viruses. I mean, it's much less of an internal, well, it ends up being internal, but if you think about it, these white blood cells are part of our immune response. So these are going to change their activity whenever the immune system changes its activities. And a lot of that has to do with how much exposure we have at a given point in time. So if there's all of a sudden more of an exposure to a pathogen, well, then we're going to trigger more production of white blood cells in the red bone marrow, and we're going to trigger release of other white blood cells from their storage sites. There's other things that play a role, but let's just leave it at that, okay? All right, make sure you review some definitions. Leukopenia, penia means too little, so it's possible to have a low white blood cell count. It's also possible to have a high white blood cell count. And then leukemia, just know that as just know the definition of that as a cancer of the white blood cells. All the rest here is extra. Okay. Before we go on to platelets, I must confess that I forgot in the red blood cells to go back and talk about hematocrit and oxygen saturation. So I'm going to go back before we finish with platelets. I apologize. It seems that, I guess like everybody, when we get back into things, sometimes we're not at our best. So I apologize. Okay, where were we? All the way back here. That wasn't it. Yes, here we go. My apologies, but at least we're going to talk about it. Didn't forget. Okay, so just switch your brain back. Again, I apologize. Let's think back to red blood cells. Red blood cells, red blood cells. So many of them. They lack a nucleus, concave shape in the middle for more surface area so it can transport more oxygen. Good. There's two clinical terms, O2 sat and hematocrit, that you very well may come across if you haven't already. Let's first talk about hematocrit. Hematocrit is really, amount of overall blood that is red blood cells. Sometimes you might hear it called packed red blood cell volume. I think this might be a clearer definition. If we look at the overall blood, hematocrit tells us what percentage of the overall blood is red blood cells. Okay, what percentage of the overall blood? Now, we've already talked about breaking it down, remember? So we talked about the plasma makes up 55% of the blood, and then the formed elements make up 45% of the blood. Well, hematocrit means what percentage of the overall blood is red blood cells. And it shouldn't be surprising that 45% falls right in the middle there. So if 45% of our total blood is formed elements, and then 99% of the formed elements is red blood cells, well, pretty much all of our formed elements are red blood cells. This is a really good number. Here's a healthy range for an adult human. Excuse me. I tend to be, I'm a cyclist fan. I used to do triathlons, blah, 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 but now I'm more cycling. And because of that, I'm familiar with some of the like Tour de France stuff. And, there's been testing because a lot of cyclists in the past have blood doped and cheated and all that, right? Well, as part of their drug testing program, not only do they test the urine and blood for actual parts of EPO and other things, they also look at hematocrit, right? And I think the upper limit is 50%. So, of course, if you're a cyclist, that would help you. But if you're blood doping, that's going to be abnormally high. So there's a healthy range. Have an idea. 37 to 50 is what I think of. All right, hematocrit, amount of overall blood, the percentage of overall blood that is red blood cells. Another definition would be oxygen saturation. And this makes pretty good sense. So we talked about hemoglobin. Hemoglobin is a series of proteins on the red blood cell surface that transports oxygen. Because you remember, oxygen cannot bind directly to the red blood cell, but oxygen can bind to hemoglobin. Well, oxygen saturation is really the percentage of hemoglobin that is bound with oxygen. Now remember, each hemoglobin can hold how many oxygens? 4. So if we have 100% oxygen saturation, that means that all 4 spots are taken by oxygen on all the hemoglobins. Excuse me. So you can see our normal value. Have an idea about that. This is pretty amazing, folks. Our O2 sat is usually between 95 and 100%. Actually, 95 might be a tad low. Usually this is a good number, 97, right? So this means that typically 97% of all the hemoglobin spots are taken by oxygen. That's how good our red blood cells are at carrying oxygen. We're very efficient. As quickly as a hemoglobin may drop off oxygen to the tissues, another oxygen is going to hop on to be transported to somewhere else. So if all 4 spots are taken on every hemoglobin, 100% oxygen saturation. Alrighty, look at all the good stuff that we've covered. So we've talked about red blood cells, and we just talked about white blood cells. So what's left would be the platelets. I don't want to go past it here. Here we go. All right, so let's talk about platelets. Platelets are a little bit more abundant than the white blood cells, but we can just simplify it and say that of the formed elements, we have mostly red blood cells, and then a much smaller amount would be white blood cells and platelets. Structurally, what are platelets? Platelets are actually fragments of cells. So platelets don't really have the structure of a cell that we think about with a plasma membrane with potentially some organelles like a nucleus, all that. A platelet is really just a fragment of a certain type of cell. I mean, the platelets do have their own specific function, but it's not, platelets do have their own specific structure, but it's not like the structure of a typical cell that we're used to. Again, sorry about that message that keeps popping up. All right, so what is the function of platelets, ladies and gentlemen? Blood clotting. Yay! I can hear the crowd. Blood clotting. Platelets play a major role in our ability to clot the blood. Yay, yay, yay. We're going to be talking all about this in a moment, so I'm going to save that for in a moment. Quick notes before we get into our discussion of blood clotting. What is the process of platelet formation called? Thrombopoiesis. We had erythropoiesis as the production of red blood cells. We had leukopoiesis as the production of white blood cells. And both of those, erythro and leukopoiesis, occurred in the red bone marrow. And now we have thrombopoiesis. Thrombo is the prefix for platelets and clotting. As a matter of fact, a thrombus is a clot. So thrombopoiesis is the process of platelet production. You don't need to know the specifics about platelet production. It's just more than we have time for. In terms of platelets, some circulate in the blood, some are stored in the spleen. Not going to worry about that. Please have an idea about the lifespan. So of the formed elements that we've talked about, platelets have the shortest lifespan. Platelets are regulated by a whole host of hormones. I've given you some examples here, but there's just so many. You need to review only what I've circled and put a star on here. All right, so this is a review we talked about. In terms of the components of the blood, we discussed plasma, and then we talked about the formed elements. Excellent. Now, as we get towards the later parts of this chapter, there's really only two parts left. One of them is what we're going to talk about now, and that's blood clotting. The fancy word for that is hemostasis. We also have some slides here on blood typing. However, there is already a lab video posted about blood typing. So when it comes to blood typing, I'm going to let you watch the lab video. Okay, so let's talk about blood clotting. Wow. Make sure you review. It's called hemostasis. And the goal of blood clotting is to stop bleeding. In other words, if you have a little cut like this, we need to be able, cut like this, right? If we have a cut, and it could be a cut like this where we see some external bleeding, or it could be internal. You know, there's tissue damage that is happening a lot, right, inside of our body. So we may not see bleeding happening, but it can indeed happen inside, right? Either way, no matter if there's tissue damage and blood coming out inside our body or outside through the skin, we need to be able to clot the blood. Without our ability to clot the blood, we would just keep spewing out blood for a long time. We would lose too much blood and we would die. That would not be very good. Here, we're going to break down the process of blood clotting into 3 steps. I like using these terms. If you read different textbooks, they may call each step something slightly different, but we're going to use these terms. Alrighty. So when we have damaged tissue, the first thing that happens is what's called a vascular spasm. I'm going to do a drawing, and I am going to apologize in advance because it's going to be a bad drawing, like every drawing that I do. So let's say here's our tissue. Could be anything, skin, part of an organ, muscle, could be anything. Look at this beautiful tissue. Well, all of a sudden, there's been tissue damage. And as a result of that tissue damage, the blood vessels that go through that tissue have been interrupted. And when we interrupt those blood vessels, well, what's going to happen naturally is that some of that blood is going to spew out. Well, the first thing that happens in the process of hemostasis or blood clotting is that we have constriction of the blood vessels surrounding the injured area. So step number 1 is we have vascular spasm. Vascular refers to blood vessels, spasm means to tighten. So we have constriction or narrowing of the blood vessels nearest to the damaged tissue. So in this picture, that would mean that these blood vessels right here would constrict. They'd become smaller. And the goal here is simple. By constricting the nearby blood vessels, there will be less blood spewing out. Right? So we're helping to keep as much blood as we can. Now, what I want to point out is the blood vessels a little further away will actually dilate. So the immediate is, let's say this is step 1A. The blood vessels surrounding the injured area, nearest to the injured area, will constrict. And that's what it's showing here, right? But a little bit further away, the blood vessels will actually dilate. And that's what's happening down here. So the goal is that the nearby blood vessels constrict to reduce blood loss, or to slow blood loss, or to even stop blood loss. However, a little further away, we need to dilate the blood vessels because we're going to need to bring in platelets for repair. We're going to have to be able to get rid of waste products from the injured area. Cool, so this would be 1B. All right, so when there's tissue damage, our first step is vascular spasm. The blood vessels that are closest to the injury site will constrict to slow blood loss. The blood vessels a little bit farther away will actually dilate as a way to help to bring in supplies for healing and as a way to help get rid of waste products. Now, there are some other things that I didn't mention on this slide. Anytime we talk about blood clotting, there's going to be a release of hormones and what we call chemical factors. I'm not going to talk about this now, but just know that with that immediate vasoconstriction, there's also going to be a release of some chemicals that cause more vasoconstriction, which then causes a release of more chemicals to cause more vasoconstriction. That's positive feedback, folks. But for now, you can just focus on, we have vasoconstriction of the immediately surrounding blood vessels to prevent blood loss, and then dilation of the blood vessels a little further away. Step number 2 would be to form a platelet plug. And I'm going to, again, draw my really bad tissue. So step 2, this is when we bring in the platelets. Remember I said one reason why we need the further away blood vessels to dilate is to bring in some of those platelets? So not very long after the initial tissue damage happened, because this all happens very quickly, we're going to bring in a bunch of platelets. And what those platelets do is they plug up the gap. So literally, we're just plugging the injured area with platelets. It's like putting gauze on a wound. So it forms a platelet plug. We just shove platelets into that damaged area. As before, but even more so, this involves a chemical process. You don't need to know the names of the chemicals, but just know that when the platelets come to form that plug, we're also going to have a release of chemicals that bring in more platelets. Now, as you read on here, these platelets, they're pretty snazzy little guys, right? So not only do they fill in the gap, but these platelets have little spiny processes that cling to the edge of the tissue. And they can also start to cling to each other. And what this means is we have an even better way to plug up the gap. So not only do we just shove platelets into that damaged area, the platelets themselves release these spiny processes to attach themselves to the torn edges of the tissue, but also to each other. And in fact, by doing so, these platelets, when they release their spiny processes, they can help to draw the broken edges together. Cool stuff, isn't it? In this picture, let me do green. These are the platelets. They're coming through the bloodstream, and then they're going in to plug the injured area. The third thing that happens is a very complex process called coagulation. Here we have, let me see, same old picture here. So to review, we have damage from the tissue. Blood is spewing out. Our first step of blood clotting is vascular spasm, where the immediately surrounding vessels constrict to reduce blood flow, and the blood vessels a little further away actually dilate to help bring in supplies and to help get rid of waste. Then we have these platelets coming in to fill in the gap. And these platelets have little spiny processes, right? Well, in step 3, here's where we want to bring in that plasma protein fibrinogen, and we want to convert that plasma protein fibrinogen into fibrin. Let me use a new color let's use orange. Fibrin is going to be, as the name suggests, a much more fibrous covering. So eventually, we're going to lay down fibrin over top of all that. And that's what this picture is trying to show. All these kind of looks like crazy spider webs. That's fibrin. In doing so, we completely trap everything underneath, and that allows new tissue to come in and replace it. So after the fibrin comes in, then we would have replacement of new tissue to bring the tissue back to where it was. That's the overall gist of this stage, right? So the key here is the phase before it, we had the platelets coming in, and yes, they have some spiny processes. But here in coagulation, we have the production of fibrin, which are these really great fibers that really cover the area, trap everything underneath, and after fibrin is there, it allows new tissue underneath to be safely developed. Now, of course, it's not that easy. this process, coagulation, I mean, we could talk about this for years, right? I'm only scratching the surface. People study this for an entire lifetime. There's college courses just on the process of coagulation. We are going to try and give you a little taste of what's involved without getting crazy into the details. So basically, coagulation is a complex series of chemical reactions. And I'm going to show you a picture here in a minute, right? If I go ahead, here's just one little schematic on what's involved in coagulation. We see all these Roman numerals. These are called clotting factors, right? Clotting factor 12, 11, 9, clotting factor 8. Oh, there's an 8A, right? Oh, we need calcium. We need so much. We need prothrombin. So it's a very complicated process. It utilizes positive feedback. So here is a case where we actually want positive feedback. Once we have a release of those platelets and then the chemicals to cause a release of more platelets, and it's true in this third phase of the coagulation as well, the reason why we're so good at blood clotting is because these chemical reactions happen very quickly. And one reason why they happen so quickly is because they benefit from a positive feedback loop. The ultimate goal of coagulation is to convert fibrinogen into fibrin. So the entire goal of all these chemical reactions is to take that plasma protein fibrinogen that we mentioned earlier. The whole goal is to take that plasma protein fibrinogen and form fibrin, which is laid down over the gap, and it traps everything underneath to allow new tissue to be formed. Good. So these are the keys. What I'm writing down, what I'm circling are the keys. Now we're going to break it down into an extrinsic series of chemical reactions or extrinsic pathway and an intrinsic series of chemical reactions or an intrinsic pathway. And we can see here those terms, right? So we have two different pathways, the intrinsic and the extrinsic. Again, I'm just trying to give you a little window into the complexity, but by all means, you do not need to know everything on this slide. That would be ridiculous, wouldn't it? Well, the extrinsic happens first. And when it says extrinsic, it's utilizing these clotting factors from outside that area right there. Okay, so extrinsic means that it's using these chemicals, using these clotting factors, not from the clot itself. These chemicals are coming from nearby blood vessels, but they're not coming from the clot itself. What happens second is the intrinsic pathway. And the intrinsic pathway can happen just in the clot itself. It doesn't need anything from outside the clot. What I want to point out, and I have it in bold, one of the most important clotting factors is factor 10. Because factor 10 forms the enzyme, you got it, that converts fibrinogen into fibrin. So, what do you need to know? The coagulation process is a series of very complex chemical reactions. Make sure I can say this right. Yes. The extrinsic happens first, and this utilizes chemicals from outside the clot. If I write it down, hopefully you will write it down also. You should write it down. And then, even though it shows them happening concurrently, the extrinsic pathway gets started first. And then not that long after, the intrinsic pathway will get started, and it does not need chemicals from outside the clot. The ultimate goal of all these is, look at this factor 10. Factor 10 is what converts fibrinogen into fibrin. And fibrin are the threads that really cover up that injured area of tissue and allow new tissue underneath to be formed. Now, if you want to impress your friends, you can have this slide up. Maybe just have your earbuds in so they don't have to actually hear me talking. But then they can just look at this slide and your friends will think you're really smart. I mean, you are really smart, but here's another way of looking at it. The first phase was vascular spasm, where there's vasoconstriction of the immediately surrounding blood vessels. Then we have a platelet plug, where we just fill in the damaged area with platelets. And yeah, they have some spiny edges. But then, of course, we have coagulation, where eventually we form fibrin. And fibrin are these threads that really cover up everything to allow new tissue to be formed underneath. Really cool, isn't it? You can see what happens at the end. I'm not going to ask you this on an exam. You can read about some of the clotting disorders. Hemophilia, I'm sure you've heard of that. And actually, I would like you to know these. All it takes is a disruption of one of those clotting factors to ruin everything else. You know, we saw in that picture. We have a clotting factor, which then causes this to happen, which then causes this to happen, which then causes this to happen. Well, for example, if you have a deficiency of, for example, clotting factor 8, well, then you can't do one of these steps, and that means that you cannot go on. Imagine this is a positive feedback loop that kind of works like dominoes. So we knock over domino, 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 but if one doesn't knock over, then nothing else can happen. And hemophilia is a very serious condition. It would mean that without proper medication or care, a simple cut could really lead to severe blood loss and potentially death. I just want to make a point about these two. These will not be on the test, but I'm just FYI. If you've heard of a thrombus, that's just a fancy word for a clot. So here's the deal. When we have tissue injury, we want blood clotting to happen. But there's other times when we don't want blood clotting to happen. Everyone's heard of this. We can think about an example of having plaque build up in the walls of our arteries. Well, over time, instead of the arterial wall being relatively thin, strong, viable, now we have plaque building up. And it means that we can't get as much blood through. And eventually, so much plaque can build up that a clot can form. And that clot can break free. This is a case where the clotting, where we have certain platelets and other chemicals that bind together into a clot, this is an instance where it's not a good thing. An embolism is when that clot breaks free. So the clot is just called a thrombus, okay? But if that thrombus, it's a clot where we don't want one, breaks free, it's called an embolism. And what's going to happen is that embolism, that clot that's now broken free in the blood vessels, is going to most likely get stuck in an area of a blood vessel that's narrow. You've heard of a pulmonary embolism. Well, one area where our blood vessels naturally get smaller is as the blood vessels go into our lungs. So this clot may be able to travel freely in the leg, but as that clot travels back up towards the heart and then out to the lungs, it might get into a really narrow vessel and get stuck. You could have a pulmonary embolism where that clot gets stuck in the lungs and it blocks our lungs from doing their job, and that person could die. This is just extra. I'm not going to ask you about this. I like to include some clinical stuff because for many people, it helps them to learn. But also, a lot of you are probably working out in the field as PCAs or LPNs or whatever. And you see these things all day, right? So sometimes we purposely want to give a blood thinner. Again, this is not going to be on the test, but someone that has chronic heart problems, someone that has high blood pressure, you purposely want to give them a blood thinner, which means that it makes it easier for your heart to pump out the blood. A blood thinner works, for example, Coumadin, because it interferes with our liver's ability to produce vitamin K. And some of those clotting factors that we looked at, those Roman numeral clotting factors, need vitamin K to be produced. So if we don't have enough vitamin K, we can't produce enough of those clotting factors, we can't clot as well, and the blood is thinner. Pretty cool, huh? You don't have to worry about that one. That's just extra. All right, folks. I'm going to leave this last part for you to watch on the lab. Here's a rare instance where our lab and lecture material really crosses over. So even for our lecture exam, make sure you're reviewing the lab video on antigens and antibodies. All right, folks, we are done with our first chapter. Many, many more to go. Let's start the semester off right. Study, work hard. If you have questions, reach out to me. I am here to help you.